Hey guys, what's up? Okay, in this video we'll see a lot of things about wound healing and repair and factors and the normal healing, the abnormal healing, the types of wounds, scar, prevention of scar, contracture, and so on. So let's get started. So wound healing and repair. Healing is nothing but the body's attempt to restore the integrity. It is a very good phenomenon, but however, the bad part is scar happens. Do you remember this guy? It's called LCM, which is the mnemonic for the factors affecting wound healing. So LCM, or I don't know if you know it, is called MCL super. So superb substance which will stick everything. It's a super glue. So MCL super is the mnemonic, or LCM for people who don't know MCL. Okay, so L for loss of tissue, C is contamination, M is mechanism of injury based on the mechanism, whether it's an incision or a stab wound like that, and based on the site, structures involved and systemic factors such as smoking, suppressed immunity, and other systemic causes like malnutrition and disease. Other factors such as local factors, which could be remembered by the mnemonic PVR, PVR cinemas. So PVR stands for pressure, vascular insufficiency, and radiation. And then about the normal wound healing, there are three steps which occur in normal wound healing: inflammation, proliferative, remodeling phases. So inflammatory phase is going to be for 3 days from the onset, from the injury till 3 days. Proliferative is between 3 days and 3 weeks. Remodeling is between 3 weeks and 3 months. Inflammatory is the first phase. So there is injury. We already know that injury is going to lead to inflammation and coagulation. Inflammation causes vasoconstriction, coagulation causes thrombus formation, which are essentially to cause the stoppage of the bleeding. After that, what happens is the platelets are tissues are going to get stimulated. They're going to release a few factors such as PDGF and histamine, serotonin, prostaglandin, and over here the transforming growth factor beta and 4, and all these things are going to be neutrophil and monocyte chemotactors. Well, PDGF, TGF, and factor 4 are all the chemotactors, but however, histamine, serotonin, prostaglandin will help this indirectly by increasing the vascular permeability, so that whatever reaches there will be able to reach the tissue site. And then comes the proliferative phase. Proliferative phase is predominantly dominated by fibroblast. Fibroblast is essential to lay down the collagen and the ground substance. Collagen, which is coming over here, is a type 3 collagen, not type 1, which is usually present in the skin. So the ground substance has glycosaminoglycans, prostaglandins, and blood vessels as well. Remodeling is a process which will start after 3 weeks and go on till 3 months of time, as seen over here. Remodeling. So so in this process, type 3 collagen is going to get converted into type 1, and at the end of remodeling, the strength is going to be 80% of the uninjured skin strength. Specific tissues, talking about specific tissues, normal wound healing in the bone, the nerve, and in the tendon. In the bone, it's due to callus formation. Callus is essentially osteoid, and the nerve is due to Wallerian degeneration, as we saw in physiology. And tendon is similar to the tissue, but however, nutrients reach the tissue through synovial diffusion as well. So, as you can see over here, this is the callus, which is the osteoid. Here the proximal nerve gives rise to nerve sprouts. Wallerian. And abnormal wound healing, there are three intentions of wound healing: primary, secondary, and tertiary. Primary is also called healing by first intention. Tertiary is also called delayed primary. Okay, so a very good wound healing is the primary intention, which is normal, where the injured surfaces are very well opposed, and it will cause minimal scar or no scar. But secondary intention, here the two injured sites are not opposed with each other, and the delayed primary is gonna cause not a very good scar but a reasonably good scar. But here it's delayed primary intention, which means here it is opposed, but it is opposed after some time. For example, as in a contaminated wound, we actually do not prefer the opposition very meaning only we wanted to heal. That is called the delayed primary or the tertiary intention. And there are some types of wounds, tidy and untidy wounds. Tidy wounds are incised, clean wounds with no loss of tissue, whereas untidy wounds, when you get an untidy wound, you go to a doctor, that's a mnemonic doc. D for devitalized tissue and other loss of tissue and crushed or contaminated wound. And that's the untidy wound. And managing acute wounds, general steps in management. So first you need to ascertain where is the injury. I mean, the person is going to be in supine position while examination, which means easily the injury in the back or the gluteal region is going to be missed out very easily, right? Which is why history is very important. Second, we have to cleanse the wound, clean using saline and irrigation. Third, explore and diagnose the depth of the wound, what are all structures involved. Four, you debride the wound, and after that, you do a repair and replace the necessary things, do a skin cover, do a closure, and that's it. Have you seen these things? These are human bites and animal bites. Those are specific wound examples. Usually, a human bite is a child, as you can see here, but animal usually bites a adult person. Well, in these wounds, you have to give tetanus toxoid for sure. And puncture wounds occur especially in hospitals where you have to immediately test for HIV and hepatitis B. It's due to injection, okay? And blood clot can also be associated with the wound. So whenever there's a blood clot, make sure you incise it and aspirate it ASAP as soon as possible. Otherwise, in the long run, it is going to cause calcification, which might require surgery. Oh my God, gross. Okay, not gross. This is called a degloving injury. Let's see about it. So degloving injury means there is a we remove the gloves, right? Similar to that only. So degloving injury, there is a separation of the skin and the subcutaneous tissue from the underlying fascia. That is the degloving injury. It is of two types, open and closed. Open means the skin is upturned, meaning it's like this. The skin is completely out. But closed means the skin is still closing the underlying fascia. The skin is not upturned. For example, this one is skin is not upturned here. The underlying fascia is still covered by the skin, which is why it's called closed. And this is open, completely open. So those are degloving. Then going to the compartment syndrome. So this is compartment syndrome where the pressure in a particular compartment is going to raise a lot. So there are a few clinical features for compartment syndrome. There will be unexplained and very excruciating pain and pain on doing passive movements. No injury, meaning no deficit will be there. Sensory loss, and also at the late stages the pulse will be completely absent. Well, if a person comes with absent pulses, then you know it's a compartment syndrome, but it's too late. Not too late because we can do a fasciotomy. Fasciotomy can be done in the longitudinal direction. It is very good because it's going to release a lot of pressure and relieve the person of the pressure in the compartment syndrome. But if the compartment syndrome is presenting late, then fasciotomy is of no use. You know why? Because if it is late, then the myoglobin from the muscles are going to be released, goes to the kidney, causes renal failure, which means at the later stages of compartment syndrome, the best treatment we give the patient is amputation. Not a new kidney, by the way, amputation. Well, this is the procedure how we do a fasciotomy. So two parallel incisions in the anterior aspect of the tibia, lit on either sides of the midline of the tibia. About the chronic wounds, there are wounds which are all the wounds are expected to heal within a period of 3 weeks. But if it takes more than 3 weeks to heal, we call it the chronic wounds. It is of two types, no, two prototypical examples: leg ulcer and pressure sore. A leg ulcer is far more common than a pressure sore, which is why I have a mnemonic for you guys. This is a picture of leg ulcer. There are few risk factors for both of them, for leg ulcer and pressure sore. There are some common features, common things first. Leg ulcer and pressure sore both have necrosis. Necrosed slough will be present in both of them. Leg ulcers can be remembered by the mnemonic CANVAS. CANVAS stands for chronic infection as in TB and syphilis. A is arthritis, meaning inflammation of the joint. Neoplasia means a tumor, squamous or basal cell carcinoma. V for venous disease, A for arterial disease, and S for self-inflicted trauma. That is CANVAS. Pressure sore has a different group of risk factors. As in, the pressure so has different group of risk factors like the old people, bedridden people, and paralytic people. Technically, who are all sitting for a long time or sleeping for a long time, those people will get pressure sores. Not usually, but often. And this is an example of a venous ulcer, which is see, it's a leg ulcer. So leg ulcer is treated using a meshed skin graft. A meshed skin graft is always better than a sheet graft because in meshed skin graft, escape of the exudate is possible and also mobility of the limb is very good. And moving on to the pressure sore. Pressure sore occurs when we sit or when we sleep. That is in these two positions. So when we sit, the dependent parts are ischium and the greater trochanter, and in this position, it's going to be the sacrum, the heel, the lateral malleolus, and the occiput, which can be remembered by this mnemonic IG sh moving. I remember it by saying that IG is a very big person, so sh, keep quiet and keep moving quietly. So IG sh moving. So I for ischium, G is greater trochanter, S is the sacrum over here, as in the sacrum, the heel, and the malleolus, the lateral malleolus, occiput. Those well, the frequency is very much important when compared to just the terms. A few other sites are also there, but they are not very important. The frequency, this order is very important. Okay, remember it. This is an example of a sore, the pressure sore, which occurs in the heel. Okay, the staging for pressure sores goes in this way: stages 1, 2, 3, and 4. In stage 1, non-blanching erythematous wound alone is there. There is no breach in the epidermis or dermis. There is no breach at all. Second, the breach site is the epidermis and the dermis. It's called a partial thickness wound. 3 is all the above plus the subcutaneous part, and stage 4 is involving the fascia also. The stages 3 and 4 together are called the full thickness wounds. So as you can already see, guys, so always prevention is better than cure, which is why prevention is very important in preventing the pressure sores. So for a sitting person, they have to stand for a period of 10 seconds every 10 minutes. What we have to advise them, we need to teach them as well. Whereas for a person who is in sleeping position, they have to just turn once in 2 hours. Okay, once in 2 hours they have to turn and sleep. And then however, if the prevention is failed, then we need to cure it. We cure it using a vacuum assisted closure. It looks like this. So there's this drain, as you can see over here. There's this drain, the tube, and this is a transparent sorry, it's a transparent adhesive. And yeah, as you can see, this is the transparent adhesive. This is the foam which they are using. Alright, so the cure is a vacuum assisted closure, which is also called the negative pressure closure. There are 4 steps involved in it. Step number 1, foam dressing. So first you need to cut the foam to the size of the wound. Second, we need to attach the foam and the drain together. Make them together. And step 3 is after attaching the foam and drain together, we need to attach it to the skin using an adhesive tape, which is preferably transparent. So pressure is given intermittently. The pressure is approximately equal to 125 mm mercury. Intermittent pressure is given. There are a few advantages of why we use vacuum assisted closure, that the bacteria is going to be vacuumed and evacuated. Interstitial fluid is also evacuated, whereas the blood flow to that particular site will increase, ensuring very good healing. About the necrotizing soft tissue infection, necrotizing fasciitis, it is of 2 types: clostridial, non-clostridial. Etiological classification. Clostridial will cause gas gangrene. Non-clostridial is mainly due to Streptococcus pyogenes, although Escherichia coli and Staphylococcus aureus can also cause it. Onset is sudden in onset, meaning in a busy OPD, the person comes suddenly. That's a mnemonic, guys. So busy as in BC, BUSY, busy, but the mnemonic is BC, and OP is the outpatient department. So busy, B is blister, C is crepitus, O for edema, and P for pain. Edema, okay, edema and pain. Pain is usually unusual. Unusual pain as in there is no history of anything, but just pain is there. Yeah, guys, but however, necrotizing fasciitis, there will be a history of or surgery before. But this is a very unusual pain, very severe pain. And ONP also stands for orange and pink color staining of the skin. Well, if we talk about colors, another color has to come to your mind, that is the gray discharge. Gray discharge also comes as called the dirty water discharge. Okay, in severe cases, however, there will be gangrene, there will be shock, multi-organ failure, coagulopathy. As you already know, guys, wherever there is an injury, there will be inflammation and coagulation. Inflammation is already there, coagulation as well comes. And about treatment is we have to take a sample and do antibiotic susceptibility test and give antibiotics. If it is not controlled, then you might have to do a surgery along with skin grafting. Okay, moving on to the next topic, which is scar. This one is an immature scar. This is a mature scar. Based on the color, I'm saying this is pink and this is pale. Let's see more about it. So immature and mature scar. A mature scar is usually pink and mature becomes pale. The immature one is harder, the mature one is softer. Immature is raised, whereas mature is flat. Right. So about the scars, guys, there are of three types: atrophic, hypertrophic, and keloid. Atrophic usually occurs in the back because there's a lot of tension in the back. Hypertrophic usually occurs in the face. It is mainly because of prolonged inflammatory phase, and keloid has a genetic component, and the most common site is this triangle drawn from the tip of the Zufi sternum, the tip of the shoulder tip on either sides. That triangle. Well, this is the triangle. In this triangle, the keloid is present in the near the shoulder. And treatment is we can give elastic garments so that it applies tension all the time. And intralesional triamcinolone injection can be given, which is a steroid. Laser therapy is also there. As always, guys, prevention is always better than cure because avoidable scars are also there. We just have to manage them correctly using scrubbing. Methods to reduce scarring during surgery is you just change the method of your suture and material of the suture. Monofilament suture and subcuticular suturing is very often associated with very less scarring, which is good. And moving on to contractures, this one is a hyperflexure contracture because there's a lot of flexion over here. And a contracture, whenever a wound crosses a joint or a crease, a flexion crease, contracture develops. Contracture is often associated with hyperflexion or a hyperextension deformity. Hyperflexion is shown here as in hyperextension is this, okay, hyperextension. And this one is a limiting one because flexion deformity, we can't say there's a deformity, but extension is a bit difficult. Treatment is simple and complex. Simple treatment is using multiple Z-plasties. Complex means we use a flap or a graft. Post-operative, however, splintage and physiotherapy is very essential. Okay, guys, see you soon. Comment down your comments below regarding the video, and do read Bailey and Lal. Text me down in the comments below about whatever doubts you have. Like my video because that's very motivating. Thanks.